today's webcast on the exciting topic of health IT security. Just as a quick reminder, everybody's phone is muted, so if you guys have questions, please do ask them in the Q&A section inside the WebEx Event Center dialog. You can see there on the screen some instructions on how to do that. I think today's webcast is probably going to go to the full 1.5 hours, so I don't think we'll have time at the end to actually answer questions live, but I will do my best to get back to each and every one of you who ends up asking questions in the Q&A section here, and I'll answer those questions probably by email within the next week or so. So quickly, an agenda for what we're going to cover. This is a big topic, obviously. You could probably spend many, many hours on each individual one of these agenda items. So I'm going to do my best to focus on the things that I think probably are the topic or the subject of most of the confusion out there and ambiguity in terms of what you need to do to be compliant as a covered entity or a business associate. But at a high level, we're going to go over sort of a legal timeline of what's happened in terms of HIPAA since its establishment almost 20 years ago now, and how that has shaped current law and really what you need to be doing as an organization to remain compliant. We'll talk about the current law as it stands right now and go over the specifics on what changed over the last 2 to 3 years. Most of you are probably aware of a lot of the changes that came with things like the omnibus final rules, but we'll go over those in some detail, especially those elements, again, that at least from my point of view, are probably the source of a lot of confusion. We'll talk about some of the threats from a security point of view and how to mitigate those threats through best practices. And the threats and best practices will be both in terms of mitigating the risk of a breach, of a protected health information breach, as well as mitigating the penalties that might fall on your organization as a result of a breach, should that breach occur. We'll talk about what I view as kind of an exciting and definitely controversial topic, which is the cloud exclamation point. We'll go into some of the implications of having protected health information hosted in this nebulous thing we refer to as the cloud, and things you need to look out for with regards to using it yourself or using third-party business associates or ISVs that leverage the cloud. It's definitely a topic that's near and dear to my heart because that's what I do pretty much every day here at Galen. And then we'll also discuss how you can, as an organization, evaluate a software vendor, whether that's a primary software vendor like your EMR vendor or other, practice management or other types of core clinical systems, or if it's a smaller sort of ancillary vendor, knowing what you need to know about the process of writing software that gets you deep enough into that domain to be able to make an educated decision about the ability of that ISV to be compliant from a HIPAA point of view. So that's our high-level agenda for today. So let's start off with that legal timeline. The elements of the timeline are actually less important than their proximity to each other. So you'll notice that it's been nearly 20 years now. It's a little hard to believe since HIPAA was signed into law under the Clinton administration. And it was a long time between that and the next activity that happened. It took a decade, nearly a decade, for most of the elements of HIPAA to actually start being enforced. Things like security and privacy rules, and then other elements that were more related to the core purpose of HIPAA, which was actually portability of insurance across things like state lines. But it took nearly a decade for any of that really to start coming into place in terms of enforcement. And then after that, especially with the American Recovery and Reinvestment Act, which I guess today, I didn't really realize this at the time we were planning the schedule for the webinars, but today happens to be the 7-year anniversary of that being signed into law. So that's good timing, I guess, on our part. But starting with the ARRA, which, as you recall, was primarily about trying to rescue the economy from the brink of collapse. But in addition to all of that portion of the legislation, a lot of healthcare modernization and regulations were enacted as part of the high-tech portion of that legislation. And then it took the better part of the next 7 years, really the next 5 years after that signing, for a lot of those things to really kick in, whether it was the breach notification rules or some of the omnibus details, final deadlines for certain types of compliance with a lot of these rules. But you'll notice that the proximity of those were all in rapid succession up until kind of the end of 2013. And so the current state of the law is pretty much what it was as of the end of 2013. There have been actually some very recent activity on the part of the Office of Civil Rights and Health and Human Services related to doing further clarification, especially in the realm of things like mobile devices and companies that are producing software for mobile devices that are healthcare related. So things like, what are the HIPAA implications of me using an Apple Watch to monitor my heart rate, and how do those implications change when that data actually flows back into an EMR eventually? There's several groups out there that are actually doing work related to that. And so they've been releasing guidelines like that and clarifications like that pretty continuously, and especially over the last 2 or 3 months. And actually just this past week, they released some more, which are pretty useful. And we've got links to those at the end of the presentation. And all of this stuff will be available, obviously, on our website. So you can download them and refer to them and browse them at your leisure. But the point is that the OCR and the government are constantly releasing updates to their to the sort of word of the letter of the law, and it doesn't change the letter of the law generally. It's just clarifying what they originally intended, or what was originally intended by the legislator. So it's definitely a good idea to keep abreast of a lot of that type of information as it flows out. So a key takeaway from that legal timeline is that the omnibus rules both clarified and in some ways changed some of the original high-tech / HIPAA legislation. And the big key ways in which it changed that legislation were related to breach notification, what the requirements for business associates are, and in addition to business associates, clarifying the difference or the lack thereof in this case of a business associate versus a subcontractor of that business associate. The penalties involved for all of the different entities that are responsible for controlling access to protected health information, expanding and clarifying a lot of the privacy rules and clarifying who needs to adhere to those rules and when they need to adhere to them. And finally, and I think probably most importantly, is that and this is evident from the auditing activity that has become frequently reported on in the media, it's got a lot of teeth now. So even 3 years ago, or maybe 4 years ago, a lot of these same rules were in place to a large extent, but the likelihood of getting audited and the likelihood of actually having penalties, civil or criminal, applied to an organization or individual were almost zero, not quite zero. There were some, but they were few and far between. And that has changed dramatically, especially in the last 18 to 24 months. You're seeing a huge budget increase for the OCR, specifically the Office of Civil Rights, and just dramatically increased auditing activity. They call them semi-random audits. They spent the last year focusing mostly on healthcare providers themselves, and they've spent the last, I'd say, 6 to 12 months starting to shift that focus, and certainly 2016 is going to be heavily focused on business associates, to some extent healthcare plans and healthcare clearinghouses. But the point is that there's a lot of teeth behind this now, and it's going to increase in frequency and increase in impact, not decrease. So if any organizations out there were only sort of tacitly or sort of playing lip service to some of the rules and regulations, now's the time definitely to fix that and to right the ship, so to speak. Because it's not really a question of if you'll be audited, it's a question of when. And that applies, in my opinion, equally to healthcare providers and to business associates. If anybody listening now is a business associate or classified as one, that audits of those organizations have been few and far between, but that's changing, and that's going to continue to change. So we'll go over each of these in some detail. So for breach notifications, it used to be that unless the breach involved at least 500 patients, 500 plus, the breach did not have to be directly reported to the OCR. They have a website, which I'll talk about in a few minutes, that allows you to actually electronically submit breach reports. And if you look at what they show now on their website, they still only publish 500 breaches of 500 patients or more. But up until recently, that was the threshold. You didn't have to report directly to the OCR a breach of less than 500 patients. So if you had 499 patients, you were good to go. And so that was confusing and a little bit contradictory in terms of the spirit of the law, and so they changed it. So the new rule is essentially any breach of PHI is a reportable breach. And the way it works is that essentially you have a window to aggregate those breaches and report them all at once. So let's say you had several breaches of 1 or 2 or 3 patients. You can aggregate those over the course of, I believe it's 60 days. It might be 90 days. I can't remember. But a 60 or 90-day period, and then you report them all in bulk to the OCR. And it's important to realize that now a breach of 1 patient is not something that can be ignored. It's no longer permissible, for instance, for your internal policies to allow for the emailing of an unencrypted spreadsheet to a coworker as long as it has less than 500 patients in it, for instance. I've seen many policies out there from organizations where there had to be explicit approval of sharing of PHI over this sort of magic 500 number, and anything under that could kind of happen, based on the discretion of the employee or the department or whatever it might be. That's no longer the case. Now virtually all breaches are reportable to the OCR, and one thing to call out about this is that risk analysis of those breaches, or of those PHI exposures, should I say, can mitigate the need to report it. So an example of this would be, let's say that you were working with a business associate, and I use this example because it happens to Galen all of the time, where a customer will email PHI unencrypted using standard email to a business associate, and let's say it has 1 or 2 patients in there, and the business associate were supposed to receive that email. In other words, as part of their job responsibilities, they were meant to see that protected health information. It was part of their contract with that healthcare organization. It was covered under their business associate agreement, so it's a legitimate use. The problem is that it was sent by email, and I'll talk about the security implications of sending PHI by email a little bit later. But theoretically, depending on the technical details behind the email systems involved, that email at one point or another was traveling over the open internet unencrypted, and that is a violation of the security rule. Now, what is the chance that during that few milliseconds of traveling over a wire in a data center somewhere on some backbone in some set of servers or interconnected servers run by Verizon, for instance, that somebody somewhere saw that PHI that shouldn't have seen it? The risk is probably close to 0. And so that does mitigate the need to actually report those breaches or that exposure of PHI to the OCR, but the rule of thumb should be, if there's any doubt, any reasonable doubt that that PHI might have been exposed to a person that should not have seen it or an organization that should not have seen it, then it should be added to the list of incidents that will be aggregated and reported in bulk to the OCR based on your organization's schedule for doing that reporting. So that is definitely different than the way it used to be before the omnibus rule clarified that. In addition to breach notification, one of the other big changes that was enacted by the omnibus rules coming into play in 2013 were how a business associate is treated. So most of the rules that apply to a covered entity now apply the exact same way to a business associate. And so just as a side note, a covered entity would generally be classified as, any kind of healthcare organization. If you employ doctors that are seeing patients, healthcare clearinghouses that are exchanging, for instance, a SureScripts would be an example of a healthcare clearinghouse organization. Payers would be an example of a covered entity. Those organizations are all covered entities, whereas Galen is a business associate. We don't directly see patients. We don't directly provide care to individuals in terms of health care, but we, through our contracts with covered entities, directly see protected health information, and so we're classified as a business associate. And there used to be some ambiguity in terms of what rules applied to business associates and how they applied differently than what applied to covered entities. For the most part, there's no ambiguity anymore. All of the security rules that apply to a covered entity now apply to business associates. And most of the privacy rules, and there is a sort of an asterisk on that, and that's the sense that generally business associates adhere to the privacy regulations and privacy policies of the covered entities that they're contracted with. And so if we're engaged with a healthcare organization as part of our business associate agreement, we will specifically agree to adhering to their privacy rules. If Galen directly provided care or interaction with patients, we would also need to have our own privacy policies exposed publicly so that our patients could see them and agree to them. And in that case, the privacy rules would apply directly to us in addition to them applying indirectly to us via the covered entities. Another example of where the privacy rules would apply would be if the business association agreement or business associate agreement directly delegated any of the requirements of the privacy rule to that business associate. So if that's specifically laid out in the BAA, which it should be if a business associate is expected to fulfill any of the duties outlined in the privacy rule, especially those duties that are related to direct interaction with patients, then that type of information or that type of rule should be explicitly laid out in the BAA. On a related note, if your organization hasn't updated their BAA since 2013, it's probably a good idea to do so. The BAA format and some of the things that need to be documented were updated as part of the omnibus rule, and so really you do need to go back and make sure that any outstanding BAAs you have with your business associates and subcontractors are updated and re-signed by all of those organizations. So, in addition to what I just mentioned, BAs are contractually and directly liable for all violations of HIPAA. Before, there was some implication in some scenarios in which the liability would flow upwards to the covered entity. That's not really the case anymore. In virtually every scenario, a business associate is directly liable. And that is actually regardless of what their contract with the covered entity says. So you could have a business associate that tries to indemnify themselves in their contract with a covered entity, saying that they're in no way liable for any breaches of protected health information. That can be ignored because the law is very clear about what responsibilities the business associate has with regards to the security and privacy rules. And so it does not matter what that contract outlines. The BAA takes precedence, and certainly the federal legislation takes precedence over any of those individual contracts. Not only that, but the business associates are absolutely liable for the actions of their subcontractors, and directly related to that, subcontractors are also considered business associates. So those kind of tie together pretty closely. So the implications of something like that would be if one of your business associates was using, given the topics of our agenda today, was using a cloud provider, and that cloud provider had a breach of some kind from a technical point of view, that cloud provider would be considered a business associate in this scenario. They're contracted with the business associate. They're handling or exposed to protected health information, and they are liable in the same way that a business associate would be directly liable, a business associate that was directly engaged with your healthcare organization. There used to be a distinction between business associates and subcontractors, and in other words, that distinction is no longer there. And finally, the the covered entity is typically ultimately responsible as well. So a key takeaway from all of this is that your choice of business associates and your vetting of business associates should be a significant factor in your risk assessments, and be a significant, and the business associate's ability to comply with the law should be a very significant portion of your evaluation of that business associate. And we'll get into a little bit later on all of the ways that you can validate that those business associates are compliant and are able to comply. But because you are ultimately responsible for the decisions that you make with regards to who you do business with, and that responsibility will bubble up in terms of violations and breaches of PHI, your organization can be held liable from a financial point of view and generally a legal point of view for the actions of your business associates if it's shown that your inaction or lack of due diligence in some way contributed to that business associate, their breach. So in terms of penalties, these generally haven't changed a whole lot. They were clarified a little bit. I won't go into each of these. I mean, they're pretty self-explanatory. The more flagrant the violation, the more obvious it was that there weren't appropriate steps taken to mitigate the risk, the larger the individual per patient penalty, and the more likely you'll get into the serious dollar figures there, like the $1.5 million per year max. One thing that's often missed about this is that the penalties involved here are for particular provisions of HIPAA. So if you had a breach that involved multiple provisions, let's say, for instance, that there was multiple provisions of the security rule that resulted in that breach, they can start to double up, triple up, quadruple up on those penalties. And that's evident from some of the serious fines that have been levied over the past couple of years on organizations. In a given calendar year, they might have had a $4+ million penalty applied to the organization, and these numbers are going to go up. They're not going to go down. They're going to get more severe, not less severe, as time goes on and organizations have had time to adapt to these regulations. And it's very important to realize that many breaches, in fact, I would argue most breaches, involve multiple provisions. So thinking that you're somewhat shielded from risk by the fact that the total dollar figures wouldn't exceed $1.5 million, which still seems like a pretty significant amount of money to me, but for a large healthcare organization that might have hundreds of millions in revenue, it might not seem that big. They can get a lot bigger than that. And that's just one of the elements that, one of the effects of having a PHI breach. Another arguably worse effect would be the public relations aspect of it, not to mention the fact that a patient's privacy was violated, but for your organization specifically, the public relations aspect of this can dwarf the financial penalties directly levied by the OCR. So in general, it's much worse, as I'd mentioned before, when intent shows that there was, willful negligence in some way, or a lack of concern, or, for instance, if policies were missing or were not completely fleshed out. And we'll talk about what those types of policies and documentation mean a little bit later. But the OCR definitely takes into account what the intent of the organization was with regards to what they were trying to do from a policy point of view and from a technical point of view versus what actually ended up happening. In my view, it's nearly impossible to guarantee that over the long haul, you will not have a breach of some kind. It could be a very minor breach and one that exposed very few, if any, patients, but it's going to happen eventually, and it's just that there's so many moving pieces in so many places that protected health information flows in and out of organizations that locking down absolutely every way that PHI could leak is almost impossible long term. And so the OCR knows this, and they do their best to make sure that they take that into account when investigating these types of breach reports. And here's a handful of kind of the big dollar figure ones over the last, I think this is over the last year and a half. And generally the pattern you'll see there is that for instance, a backup tape lost in transit from South Shore Hospital there at the bottom. That was a pretty significant penalty, $750,000. There was some, doing research on that, there was some lack of policies and procedures in that case. But in that case, it wasn't that they were extremely negligent or were flagrant in their IT policies or anything like that, and so they were not hit with the maximum fine. Whereas Signet at the top, that was a very different scenario where it was actually a combination of lack of privacy rule compliance. They weren't, for instance, giving out patient information to patients upon request in a timely manner, and that was combined with a wide variety of security issues with an online database that actually at one point or another was exposed to the internet without any real authorization on top of it. And so there was a combination of things that resulted in a pretty significant, at that point, and still at this point I believe, the largest fine ever levied. But again, I promise that these fines will go up, not down. They're ramping up in this respect. In terms of the privacy rule clarifications that were offered as part of the omnibus legislation, generally it was mostly expanded guidelines and clarification related to when is it legitimate for a healthcare organization to share PHI with third parties that aren't directly were typically considered part of the healthcare delivery process. So things like marketing communications purposes, some of the other ones that I don't mention in here but are also the case are related to genetic databases or genetic profiling, so offering up to some extent de-identified genetic information into sort of large databases so that genomic research can take place. That was clarified as part of the omnibus legislation. Disclosure for the purposes of payment, immunization reports for schooling and public health safety issues, generally clarifying what health plans have a right to access, and then the specifics related to what should be in an organizational health privacy policy, who should see that privacy policy, or should those privacy policies be published, and who really is required to have a privacy policy. All those things were clarified as part of the omnibus legislation. So now that we've kind of gone through the changes and clarifications in the legislation over the past couple of years, let's talk a little bit about the specific threats to healthcare IT security. And some of them are going to be obvious and some of them a little bit less obvious. So obviously the first one that I'm sure many of you are thinking of is hacking. If I had done this presentation a year ago, I would have been able to say that hacking represents a very small percentage of all protected health information breaches, and it still does. It's not a small percentage, but it's certainly not the #1 threat. However, it's also the fastest growing one. So 2015 was actually the first year that the number of breaches related to hacking were greater than all of the other breaches that have been reported. That is reported breaches, but I think that data point is a valuable one. Physical theft is one that is, I think, another pretty obvious one, coming in and stealing a laptop, for instance, or even stealing paper records for that matter. It's an easy one. It's, the stat I like to cite sometimes is that when it comes from theft of identity, and people stealing credit card information and financial information, a lot of people are worried about their online presence, and you should be. You should take those precautions and make sure you're doing online banking and online transactions with legitimate businesses and all of that good stuff. But still, the #1 way that somebody's identity is stolen, even today in 2016, is somebody stealing your mail. And so the physical theft of information, whether that information is stored on a computer or stored in a letter, is still a significant source of PHI breaches. Employee and business associate, for that matter, misuse or unauthorized access. This is one of the many reasons why evaluating business associates is critical. You are eventually liable in one way, shape, or form for the actions of your business associates. And so making sure that those business associates and those employees are trained appropriately, are restricted in their access, is critical, and we'll go into some detail on that in a few minutes. Negligence and loss, leaving and I've done it quite a few times, leaving my phone in the back of a cab or in the back pocket of your airplane seat, which happened to me recently, and I'm still recovering from. That is a significant source of the loss of PHI, and those are all reportable breaches. And in that case, losing your laptop in the back of a plane, pocket seat pocket, that could be a reasonably minor, certainly a reportable breach. It could be a reasonably minor breach if that laptop was encrypted. Or it could be a significant issue for an organization if it was unencrypted. And so there's lots of ways to mitigate those threats. So the question is, given limited resources, which we all have, which of these things are the things that we should be focusing on the most? And luckily, the OCR publishes all of the breach data on their website in an easily consumable spreadsheet. And so it was easy for me to go and say, well, let's figure this out rather than relying on pundits and relying on third parties. Let's go and see exactly where the primary the primary sources of breaches occur. So which of these are the primary ones? And I'm sure a lot of you are guessing hacking, but it's not. The primary way that PHI is breached, at least so far, has been theft. Followed by unauthorized access and disclosure. So, theft being things like stealing a laptop, stealing a phone, stealing physical papers, imaging data, stealing a CD or a DVD or a USB key or what have you. So the physical taking of something. So that does not include things like theft via hacking, and it includes only physical theft. And then it's followed by unauthorized access. So that would be inappropriately looking at a celebrity chart, for instance, or a family member's chart in an EMR, a business associate having inappropriate access to a source of PHI, like a database that they had no reason to have access to, any kind of access in terms of, there's no hacking involved. It was access might have been granted, or it was permissible in the sense that they had a login and password, but the information was inappropriately viewed when they had no reason to do so. And you'll notice way down on the bottom left there's hacking. Now again, as I mentioned before, it was the #1 cause in 2015. If you looked at all of these breaches just by date in 2015, hacking would be #1, followed by theft, followed by unauthorized access, followed by all the rest. So it's certainly a growing one, but it's not the #1 right now. So that might mean, for instance, if you're doing your risk assessments and figuring out where to put resources in terms of mitigating some of these risks, you'd certainly concentrate on hacking just because it's a rising factor, but you'd also concentrate on physical security of your assets and making sure employees are trained, for instance. In terms of where the breaches occur, so this would be what organization is primarily responsible for these breaches. Unsurprisingly, the healthcare provider, given that they're the custodian of most of this data, is also the place where most of these breaches occur. They have the most attack surface area and most exposure, so it's not really all of that surprising. But second place there are business associates, and again, one of the themes of this presentation is making sure that your business associates are well vetted and scrutinized as much as you can, because they are a rising and significant source of PHI breaches. And, as I mentioned before, while they are now directly responsible for they're directly liable for these breaches, that does not absolve the covered entity for their liability. And health plans obviously are exposed, and they have a large amount of PHI that they're a custodian of, but they also have significant resources to lock it down. And at least right now, they're also not a primary target. They're hacking and other sort of nefarious activities. It's just much easier to target smaller organizations, whether those are business associates or individual healthcare providers and healthcare organizations, rather than a Blue Cross Blue Shield or a Medicare. They're undoubtedly a target, but they're a harder to penetrate target versus some of the lower hanging fruit. And so that's reflected in the sources of some of these breaches. In terms of location meaning where did the data physically live when it was stolen. Again, this goes back all the way to 2009, I believe the dates for this data goes back to. So still a significant portion of these are paper and film records that are being physically stolen or exposed in some way, whether they were left someplace they shouldn't have been left unsecured, or whether they're actually stolen and used for nefarious purposes or what have you. It still is a big source, but it's not a rapidly growing source. By far the most rapidly growing sources of breaches in terms of where the data is physically located are things you can pick up and carry away with you outside of paper. So laptops, tablets and phones, desktop computers, those are all very significant and rapidly growing places where PHI might live, and they're often stolen for reasons that aren't directly related to the fact that they have PHI on them, but that doesn't really help you a whole lot when it comes to the penalties and when it comes to the risk to your organization. So you have to take, in my view, a strict policy when it comes to locking down environments that might contain PHI, especially things that are highly portable like tablets and phones. And you'll notice that email and EMR are significant sources. They're non-trivial. I cut out a handful of sources here that were in the single digits. But, you know, despite the fact that EMRs seem like they might be the #1 place that that data is inappropriately accessed or hacked into, they're actually not the primary target. It's much easier for me to go in and pick up a laptop and walk out with it than it is for me to hack into EMR generally. And so that is where a lot of these breaches are happening. And again, the pattern you're going to see is as the low-hanging fruit of potential PHI locations is cleaned up and locked down, because it's also some of the more easy tactics you can take to lock down some of this information is locking down some of your mobile computing devices, that the pattern here is going to shift. You'll see that start to shift more and more towards the quote-unquote harder to access environments like the EMR, like your server and data center and things like that. And finally, the size of the breaches, this also goes well with that previous slide, where you'd expect that my phone probably doesn't contain 100 million patient records. It might contain an email with a spreadsheet in it that had 1,000 patient records, or maybe a PDF with 1 patient record. And so if theft of portable devices was a significant source of breaches, you'd expect it to be, most of the breaches to be on the smaller side in terms of the quantity of patients, and that's exactly what we see. The vast majority of breaches that have been reported are in that sort of 10,000 and under range. You do have a handful of ones way over on the right there in the many millions of patients. Those are almost universally payers where a payer system is compromised in some way and a significant portion of the population that they manage or that they pay for was exposed. And so one of the breaches, for instance, on that far right column was a 70+ million patient breach from one of the payers in the United States. So what are the types of best practices we can do to minimize the risk to the organization? And the way I view it is there's really two ways to look at this. There's ways to mitigate the risk of it occurring initially. So I classify that as risk mitigation. How can I prevent the PHI breach from ever happening? That's always obviously the best way to do it, because if you can prevent it from ever happening, it's not just the harm to your organization, it's also, you're also preventing the harm to the patient themselves. And there's also penalty mitigation, i.e. if you assume eventually it will happen, and I think that that's probably a safe assumption for virtually everybody, what can you do to minimize the risk to your organization from a financial and legal point of view? And so, starting with the first one, the risk mitigation, you know, the big targets are obviously IT. You know, there are technological ways to fix things or to mitigate the risk of being the custodian of this protected health information. Physical security, as I've been trying to kind of drill in here, is a big important one. So the fact that most PHI is stolen physically means that physical security is a good way to answer that. It's a good way to minimize the chance that you're going to get PHI removed from your organization or breach in your organization. Doing risk assessments is important, and this is one that's very often missed, and the way I know that it's very often missed is by looking at the notes for the OCR findings for when they go and actually do audits on organizations or investigate breaches that have been reported. conservatively, I would say half of the reports that I read of the sort of top 50 or so incidents involved organizations that did little or no explicit risk assessments on their infrastructure and on their employees and people and assets. And it's really important. It's easy to ignore, and the problem is if you ignore it, you're almost certainly exposing yourself to a lot more risk than you normally would. And later on, during the penalty phase, if you're not doing risk assessments, you're dramatically increasing the chance you're going to get to that phase. That's going to be taken into account. The fact that a thorough risk assessment was not done will not look good in the eyes of the OCR when it comes to that penalty phase. Employee education and training. So this is, in my view, a lot more than just saying, hey, don't go accessing patient charts that you have no clear clinical reason to access or business reason to access. It goes into a general IT awareness training, so knowing about how to avoid phishing attacks, knowing about how to avoid even things like social engineering, somebody pretending to be the IT help desk or what have you. A lot of the training that Galen does is related specifically to sort of general computer education, knowing about the risks of being in a highly connected, highly interconnected environment when it comes to computing, and the fact that there's a lot of people out there trying to gain access to your system or fool you in some way for personal gain. Including that as part of your general quote-unquote HIPAA training is critical. And then finally, again, and I'm sorry to keep harping on it, but it's super important, BA and vendor selection, knowing how to evaluate third parties that you want to work with that are going to be exposed to protected health information and having a reasonable certainty that those organizations are in a position to comply the way they need to be able to comply to satisfy your legal requirements. And in terms of penalty mitigation, it's mostly about documentation. So policies, again, risk assessments are a big one, being very careful about recording every decision that's made and all of the factors that went into that decision. All of that information goes into demonstrating the intent of the organization. So a software vulnerability that leads to a breach of PHI, for instance, that will look much worse if you had no patching policy in place or no antivirus policy in place or no IT training policy in terms of what IT should be responsible for in terms of patching mission-critical infrastructure that might be very patch sensitive, if you will. And I'll get into some of those implications in a minute. But documenting those policies and documenting what your original intent was goes a long way to minimizing how poorly it will go for you during the process you'll have to go through with the OCR. So I have a whole slide here dedicated to encryption. So we're going to go through each of the sections I talked about a second ago. And the first one was IT, and I have an entire portion of this presentation dedicated to encryption for two big reasons. One is it's, in my opinion, the single easiest thing you can do. Easy, I guess, is a relative term. Encryption can be a little scary from a technical point of view and just understanding how it works. It seems somewhat magical on the surface of it. But it's the single easiest thing you can do to truly mitigate the risk that an inevitable breach of your organization in some way or another, whether that's a physical theft or whether that's somebody hacking into your network or what have you, will result in that PHI actually being used in a nefarious way. They might gain access to the database, they might gain access to the laptop, they might gain access to whatever, but the chance they're actually going to be able to use it if it's properly encrypted is close to zero. And that obviously helps with your penalty phase, but it also helps keep your patients safe from that information being used against them. So as an aside, one might wonder why PHI is such a significant target for hackers and other nefarious types of people coming in trying to steal it. Why is it any different than a credit card number? And that's that the financial industry has been dealing with this for a very long time, and they have both legislation and systems in place to mitigate the risk of financial data being stolen, both the risk to them and to some extent the risk to their customers, i.e. the credit card holder or the bank account holder or what have you. And obviously there's also federal protection in terms of, having an FDIC-insured account to make sure that if that bank went under or there was some incident that was covered by the insurance, that the federal government would be there to sort of pick up the pieces and put money back in people's accounts and make sure nobody's lives were ruined, at least not as much as they normally would be. That really doesn't exist yet for the most part in the healthcare industry, and stealing somebody's identity is made much easier when you have a full health record to back up your claims about who you are, and it also helps you steal their identity in terms of getting services from a healthcare point of view. And those services, once they're rendered, it's not like a credit card can be canceled. It's not like your surgery can be undone. That's unlikely, but it happens. And so the value of a patient chart and their full medical history is an order of magnitude greater than the value of a similar credit card, a stolen credit card number with enough information to use it on the sort of black market, if you will, the dark web. And so that was a bit of an aside, but in all of these cases, encryption can really help mitigate those risks in a very real way. So where should encryption be used and how should it be used? So, the phrase you'll often hear people say is it should be encrypted at rest and encrypted in motion, and that's true, but what does that really mean and where does it apply? And are other places you don't really need to do that? So at rest, it means sitting on a hard drive. It means not actually flowing over a wire. It means sitting on a device stored in long-term storage of some kind. So you're on your phone, on your PC, on a server, in a database. In all of these scenarios, those devices should absolutely be encrypted. Any device that may contain PHI, that has the possibility of containing PHI, should absolutely be encrypted. And that, by the way, goes for servers equally as much as it goes for everything else. So many organizations go through the trouble of encrypting, every one of their employee laptops. Where even employees that might not necessarily be typically accessing PHI, and that's good, and you should do that. You also need to do that to their phones. If they have access to any clinical systems or communication systems, for that matter, that might be used to share PHI, for instance, even email, their phone should be encrypted. The policies that you have in place, your mobile device policy, should say if you plan on using this device in any way, shape, or form as part of your employment with our organization, it has to be encrypted. And there are other policies, for instance, like being able to remotely wipe that device in the case of a termination. So those policies have to be in place. But even more importantly than that, in my opinion, is the fact that your servers need to be encrypted. And this, by the way, goes for your servers involved in your primary clinical systems, like your EMR, like your practice management system. I would venture to guess that a significant portion of the people listening to this right now are running electronic healthcare record systems on completely unencrypted infrastructure. The databases are not encrypted. The servers on which they're running on, their hard drives are not encrypted. It's extremely common, and for some reason there's the thought that just because they're sitting in your data center or sitting in a locked room somewhere that they do not have to be encrypted, and that's just not true. They absolutely have to be encrypted, and how you encrypt them, that's a more detailed IT question, but there's a wide variety of ways to encrypt them without requiring that your EMR vendor jump through hoops to support it. There's transparent data encryption techniques for database servers. You can encrypt data on servers at a level that's kind of at the operating system level, which generally mitigates the need for the applications running on those servers to really have any idea that there's encryption involved at all. No matter what, you absolutely have to be able to encrypt those servers, even if they're in a secure data center, so to speak. The security rule doesn't end at your data center's walls. In addition to that, the technique you use to encrypt them should be centrally managed so that you can provide proof that those devices were encrypted. So let's say a laptop in your organization or a mobile device of some kind was stolen, and you report that breach, and the OCR says, well, was it encrypted? And you say yes, so they're going to say prove it. And you need to be able to provide documentation of it the last time that device was verified to be encrypted, and the best way to do that is by using some third-party tool, whether that's something built into Windows or whatever operating system you're using, like BitLocker, or whether that's Sophos, a third party that Galen happens to use. Any of these systems that you choose need to be able to have central reporting capabilities on all of the devices in your organization that it's responsible for encrypting. In addition to being encrypted at rest, it's got to be encrypted in motion, and again, this includes internal communications. So I wanted to make sure I kind of kept most of this discussion at a high level and just call out the gotchas that a lot of people might be missing, rather than trying to have this be a full-fledged IT training session on locking down an organization. That would just not be possible in a 1.5-hour webinar. And this is one of those things that is in virtually every environment. You're going to find some system somewhere that transmits PHI on an internal network that is not encrypting that communications. And the most classic example of this that we see very frequently is the communications between your EMR web servers, for instance, and your EMR database server. That is often completely missed in terms of determining what needs to be locked down. And in virtually all cases, that is a communications channel that absolutely needs to be encrypted. And there's lots of ways to encrypt that information, and virtually all vendors have some way to configure it to handle that, or there's something you can do at the network level to make sure that that communication is encrypted, but it's got to be done. And just because it's in your data center does not absolve you of the need to encrypt that communications. Now, what is the risk of PHI leaking on an internal network where you're controlling that network and controlling the channels between the web servers and the back-end servers that are, doing the processing or storing the data or whatever it is? It's probably pretty minimal. It's probably fairly close to zero if you've got good general IT practices in place, but a lot of risk mitigation when it comes to IT is about defense in depth. It's about having layer upon layer upon layer of security measures so that if any one of those security measures fails or has a lapse in some way, that another one will be there to pick up the pieces and make sure that a breach doesn't occur. And that, plus, it's required by the security rule. Encryption in motion is not restricted to outside of your data center. It's obviously a very good idea outside of your data center, and it's often called out in network diagrams. In many cases, when you're doing architecture diagrams for a solution and you're trying to do risk mitigation, they'll circle or highlight the communications leaving the network saying, hey, are we making sure that's encrypted? That's very good, but just because it's leaving the network doesn't make it special. Inside the network also needs to be encrypted. And don't forget, and this is related to that, don't forget third parties. So are you using a third-party file sharing service? I assume that if you are, that they're a HIPAA compliant service that's able to sign a BAA with you. Assuming that's true, are you making sure the communications between your users on your network and that third party is encrypted? What about your email communications? Anything that is with third parties, make sure that communication channel with that third party is encrypted from start to finish. And finally, at least in terms of encryption, where the keys to the kingdom are stored is pretty important. So, and this is in many, many cases a weak link in the chain of command, so to speak, or in the chain of security when it comes to encryption. So if your organization, for instance, leverages a central encryption system, and that encryption system has a master password or a master key of some kind, where is that key stored? Ideally, in my opinion, it should be stored in a third-party secret service, which has a separate set of credentials to access it, which can then be controlled by your organization independently. And it's best, in my opinion, again, to leave the securing of the secrets themselves to an organization that does nothing but that, whose sole purpose is to secure these. There's many out there, and there's quite a few that will sign BAAs with healthcare organizations to store their secrets. And I'd highly encourage any organization that pretty much every healthcare organization is going to have secrets they need to store, whether those are things like certificates for your websites, like your SSL certificates, or whether those are master passwords of some kind, or master credentials, backup credentials for your domain, your Windows domain, things like that you want to keep safe, and you want to have multiple human beings have access to them in a secure way. Use a third-party secret service to try to lock that stuff down. So in terms of outside of encryption, which is kind of its own domain there, there's sort of three areas from an IT security point of view we really need to focus on. There's the perimeter, which is essentially the separation between your internal network and your external network. That's not a word. Your external network. There's your internal network itself. What you're doing inside the network to lock it down. And then finally, there's your continuity plan. So what's your plan from a backup point of view? So we'll talk about perimeter first. So the most obvious place to start in terms of IT infrastructure is your firewall. And firewall technology has evolved a lot over the past decade. I used to be an IT pro. I can't really consider myself an IT pro anymore. The state of this industry has advanced significantly, even just in the last, say, 3 to 5 years. You've seen a lot of very interesting advancements in terms of firewall technology. And one of the most sort of interesting ones, which when I initially heard about it, irked me, but now that I really truly understand it, it makes a lot of sense, and it's a good thing. It's not a bad thing, is subscription-based updates for your firewall infrastructure. So in the same way that you have updates for your antivirus software so that it knows when, there's new viruses out there or new malware that it can recognize, it's constantly updating that, and you generally want to keep those as up to date as possible. The same goes for firewalls. Some of the more advanced firewalls out there are able to essentially download a stream of updates from the firewall vendor that give them instructions for detecting malicious patterns of activity, of network activity, and that's an incredibly good way to prevent the bad guys from even getting in. So this originally was kind of formulated to handle things like distributed denial of service attacks. Those are oftentimes, in order to be able to stop those, you have to stop them in many places all at once, and so having the ability to distribute those policies across many organizations simultaneously was useful for stopping those large-scale attacks. But more recently, it's been incredibly helpful at stopping certain patterns of attacks. For instance, a classic attack, which there's still countless pieces of software that are vulnerable to, is a SQL injection attack, where you go and you try to pass some specially crafted structured query language code to an application and hope that it doesn't properly escape things and doesn't properly handle that. And it shouldn't be accepting SQL to begin with, but it doesn't properly handle the arguments that are being passed to it from a web page or what have you, and seeing if you can use that to drop a database or do something scary. And generally, that pattern of activity is actually pretty easy to see at the network level and can be blocked. It's almost never legitimate and can be blocked. And there's nuances to it, and those nuances require kind of constantly updating signatures. And so having that subscription-based update is a really good idea. And older firewalls generally don't have it. Anything sold in the last 3 to 5 years, or at least 3 years, we'll usually have the option, and I'd encourage you to take that option. Initially, as somebody who's partially responsible for choosing vendors for that type of stuff for Galen, it irked me, the idea that I'm buying a, expensive firewall and then I have to continuously pay to sort of keep it functioning really annoyed me, but there ends up being a pretty good reason for it. And in addition to all that kind of stuff, the most modern firewalls are going to have the baseline capabilities like intrusion detection and being able to inspect that traffic in a stateful way to really see these types of patterns of malicious activity. And it goes way beyond the sort of standard role of just blocking traffic at sort of the port level, and it really is required these days for having a robust perimeter security policy. So assuming you want somebody to be able to get in past the firewall, well, what's the best way to do it? And a big part of that, especially in an organization that has a policy of allowing providers or other people that need to access PHI to access it outside of your network, let's say from home on their laptop, having a modern VPN in place is a requirement. And that means basically not point-to-point tunneling protocol. That's what PPTP stands for. That's essentially been long since compromised. It was sort of officially compromised a little over a year ago, but there's been rumblings of its compromise for quite a while. And so that should not be set up. And generally, you're not going to see that in most organizations these days. One of the nice benefits, by the way, of moving to a modern VPN, especially an IPsec VPN, is that you can, in many cases, have that VPN be just something that happens in the background. that doesn't have to be done explicitly by the user. So in a traditional VPN setting, I have to quote-unquote dial into the VPN. That's a archaic way to phrase it, but that's what it was, right? I'd open up an application or a control panel or something on my computer, and I'd say connect. I'd have to explicitly connect, and only then would I be able to resolve that internal web page or access my EMR or whatever it is. And these days, it's actually possible to set up these sort of ambient policies that just make it so that this computer with this human being using it just always has access, is always persistently connected to our internal network and in a very secure way. And so it improves end user satisfaction. It reduces things like help desk calls about, hey, I can't connect, my VPN's not working. And it's just, much more secure than sort of the old way of doing things. And then making sure, assuming you're allowing people into your network via VPNs and otherwise you've got your nice firewall set up, locking everybody else out, what's another way somebody can get into your network? Well, they can sit in a van outside your building and access your wireless access point. And, that used to be called war driving back in the day, where somebody would drive around a town looking for open wireless networks, which thankfully are fairly rare these days, but they'd be looking for open wireless networks that they could then do nefarious things with or just use to access the internet or what have you. And so the best ways to protect against, assuming you do have a wireless access point or infrastructure in place, the best way to protect against inappropriate access to that is obviously using the latest and greatest authentication protocols. Always favor, whenever possible, the most restrictive access methodology over allowing older devices to connect. At this point, there's virtually nothing that doesn't support WPA2 and some of the sort of higher-end encryption mechanisms and handshake mechanisms, so it's very unlikely that you're going to need to allow for, say, WPA1 or even older protocols to access your network, and your policy should favor, whenever possible, not allowing that, because they're just pretty trivial to hack. These days, anything but WPA2 can be hacked in a matter of minutes or hours or worst-case scenario days, whereas these take much longer. And if you've got the appropriate policies in place in terms of things like key rotation and a lot of things I won't dig too deep into here, this wasn't meant to be an IT specific presentation, so I won't dig into a lot of those things, but there are ways to mitigate the risk of the attack surface area of even these protocols. But another great way to do it is make sure you're segmenting your guest networks, and I'll talk a little bit about network segmentation generally in a minute, but having a dedicated guest network for any person visiting your organization who's not a person who's an employee or signed to BAA or what have you is a must-have. Every single place where that might happen, you should have a guest network. And I would argue you should have basically almost always have a guest network everywhere, which is also password protected. This is not a public guest network, but it's segmented either physically or through the wireless access point itself. So that way, should somebody gain access to that guest network nefariously, at least they're kept contained in that segmented segment rather than having access to your entire internal network. And so finally, if we get to inside your network, obviously having up-to-date antivirus and malware, this is kind of old hat at this point. Pretty much every organization out there would have this. I would recommend that you make sure you deploy your antivirus and malware detection software to servers too. I mean, you'll need to put in place exclusion policies that match your software vendor's requirements. That's kind of a given. But servers are not immune to viruses, and in fact, they can be a really great jumping off point and access point to very critical information. If something gets onto your network and spreads to a server that happens to have a large cache of credentials onto it, then those credentials are compromised, through other types of brute force hacking. That can lead to further compromises of the rest of your network. So servers are actually highly sought after virus targets and worm targets. So it's a really good idea to lock those down. It's not just human beings using a machine that exposes them to viruses. Plenty of viruses, namely sort of the worm variant of a virus, spread over a network independent of human activity, all by themselves. And so having this software on those machines, even servers, helps further mitigate that risk. Again, it's a defense in depth idea. Centralized auth-NZ. So auth-NZ means authentication and authorization, whereas authentication is knowing who somebody is, verifying their identity. Authorization is determining what that human being, once verified, can do. So it's kind of like the difference between your login and your password, i.e. your authentication, versus your permissions to do XYZ in an EMR or on your computer or whatever. So that's the difference between auth-in and auth-z. Having that be centralized whenever possible across all of the systems that your users access. So if you have third-party vendors that provide some service to your users. You know, a great example of this that Galen uses is we use Office 365, right? We have a subscription with Microsoft to use email and a bunch of other things, and the way that we authenticate with our email is through a centralized repository, namely our Active Directory system. So we use Windows, we use Active Directory, and all of that is centralized at Galen, so that when we log into our email, even though our email is hosted by Microsoft, it's still the account that an employee at Galen uses to log into their machine, log into their PC or their laptop. And having that be centralized has a lot of great effects. It allows you to lock down password policies, lockout and expiration policies. There's lots of details of the HITECH Act that kind of lay out best practices in terms of what those policies should be and what the minimum should be, and things like password length or what have you. And having one central place to be able to govern all of that makes it much more likely it's going to get done. It also, by the way, helps a great deal with offboarding. So when you have to end employment of a person in your organization, having to go to a half a dozen different systems to shut off access greatly increases the chance that that's not going to happen. And if one of those systems happens to have some ancillary access to PHI in your organization, that's a big problem. And so that can be mitigated further by making sure that whenever you can, it's all centralized. And generally, most third parties that work with healthcare organizations will offer some kind of federated authentication system, whether that's compatibility with things like Active Directory Federation services or one of the other many directory services, auth-NZ systems. Generally, those third-party vendors will support something like that. And if they don't, you should work with them to try to get them to support it or not choose them, because it's a big deal when it comes to locking down access to your organization. Using never share accounts. I mean, some of these things should be obvious to everybody. Sharing an account is bad for a wide variety of reasons. It prevents organizations from identifying exactly who's doing what. And it also probably means you're sharing passwords. It's just generally extremely bad practice. Multi-factor authentication can actually help mitigate the risk of people sharing accounts and credentials. And when I say multi-factor, I mean either ideally something that includes a physical access key in addition to something you know. So a password plus a key fob, for instance, would be ideal, or a password or a PIN plus a retinal scan or a fingerprint. Those types of technologies maybe 5 years ago were unreliable and difficult to implement, and these days they still can be challenges from an IT and infrastructure point of view to implement them, especially with some older third-party systems you might have to work with that might not support it, but it's generally possible, and it's a good place to put investment dollars in terms of locking down your infrastructure, because a great way to mitigate the risk of compromised accounts is by requiring that multi-factor authentication. My favorite example recently is, the Surface Pro 4s now have what they call Windows Hello, but basically it's facial recognition that looks at the thermal patterns in your face to determine who you are. And it's pretty amazing and actually has a great user experience, because I can just look at my computer. I can't do it because I don't have a Surface Pro 4, but if I did, I could just look at my computer and it would log me in. And you could require that they look at your computer and that they type in a 4-digit PIN, and even that 4-digit PIN plus that other factor is way more secure than even a, say, 16-character, very random, hard-to-remember password. And one of the reasons, by the way, that it's more secure than that is that those big random passwords that require exclamation points and underscores and, numbers and can never be repeated and all these horrible requirements, the more complicated they are, the more secure the individual password is, but also the far more likely that person's just going to write it on a sticky note and leave it on their monitor because they can't remember it. And you require them to change it every 30 days and forget about it. Your chances of that person coming up with a password that matches a complex policy and they're not writing it down rapidly approaches 0. And so one way to mitigate that, aside from multi-factor authentication, is to use something like a passphrase approach where, I can't remember what the classic one people use is, like a, red horse Sunday something, right? So you come up with a long multi-word phrase, and then you use a mental rule to pick out the different elements of that phrase you're going to use for the password, or you use the entire phrase and then you have a mental rule that allows you to change certain elements to make it slightly more random. So maybe replacing certain letters with digits, for instance, replacing, the classic one where you replace E's with 3's, but normally that doesn't help a whole lot from a security point of view, but applying that to a passphrase that might be 20 or 30 characters long, it makes it easier to remember, and it dramatically increases what's called the bits of entropy in that password. It makes it extremely hard for brute force attacks to hack because the amount of combinations that have to try to attack that go well beyond their computational capabilities and their storage capabilities generally. It's an arms race, there's no doubt about it, but a 20-character passphrase with just one number and maybe one punctuation mark is much, much, much more secure generally than a 10 or a 12-character password that's all random, because I can very easily, using things like the power of the cloud, ironically, attack a 12-character random password and have a reasonable chance of getting it, depending on how much money and how much I really want to, how much money I want to spend and how much I really want that password. I've got a pretty reasonable chance of hacking into that. Having clear offboarding procedures is all related to this centralized off-N, off-Z approach. So knowing what systems and what things need to be taken from a employee when that employee's contract is terminated is made all the more easy when you have a centralized system to manage that whenever you can. Patching and change control, I mentioned this previously, making sure that you have a clear policy when it comes to patching. In my opinion, your default policy should be to patch, not to delay patching for a standard amount of time while you test systems. Your default policy should be apply patching to those test systems and see if they break, rather than say we never apply patches for 3 months to let things flush out in the community or what have you. Your exposure to hacking because of a lack of proper patching of your environment is dramatically greater these days, at least, than the chance that a patch is going to break one of your systems. Is the chance 0? No, it's not 0 that a patch won't break one of your systems, which is why you should apply it in a controlled manner and in controlled systems, but you should be very aggressive on the schedule for that, and it's a good place to invest dollars to make sure that you're as up-to-date as possible. How many of you out there are still required to use IE8 for your EMR? That kind of stuff is just simply not acceptable. Sometimes you have to accept it because your vendor forces you to, but the industry as a whole, healthcare industry as a whole, has to really kind of band together and force vendors to update their software to support the latest and greatest. IE8 has been out of support for years. That's an incredibly old browser. It's just riddled with security holes, and you're asking for trouble. And that, for that matter, goes for IE9. It goes for many browsers that are out of date, more than just a few months out of date for that matter. And so having an aggressive patching schedule is extremely important. So when Patch Tuesday comes around, or I guess that policy has been abandoned these days, but when patches come out, apply them as soon as you possibly can to test systems, and then see if they break. Don't have a delayed schedule where you wait for 3 months after a patch is applied, or wait for 3 months before you apply patches. That's just asking for trouble. Make sure you restrict external devices that can be plugged into computers. And this is less about people putting things onto those devices they shouldn't. So for instance, storing PHI on an unencrypted USB key, while bad, you can put in place policies like, for instance, that restrict USB devices that aren't encrypted or what have you. It's less about restricting information getting out of a system and more about restricting what happens to get into the system. USB and other external devices are a great attack vector for bad guys. I'll talk about this in a few minutes, but a really great social engineering technique is to drop a USB key in the parking lot of a health system or a hospital. I guarantee you that USB key will be picked up, and I guarantee you somebody's going to plug that in. It's just almost impossible for somebody to resist, ooh, what's on that? And if you've got a policy that prevents the operating system from recognizing those external devices, it further mitigates the risk that device is going to be compromised. Segment your network. This is kind of similar to the guest network comment I made earlier, but you've got to make sure that your network is as segmented as possible, and this is the defense in depth technique. So many of you are familiar with the concept of a DMZ, a demilitarized zone on the network, where your servers that might be accessed outside your network are stuck in a segment of that network which is locked down. So that way, if those servers, which are inherently at a higher risk for compromise, are compromised, the extent of the compromise is limited to the other machines in the DMZ rather than escaping onto your network in general. Apply that same idea everywhere you can within reason. So if two parts of your organization rarely, if ever, need to communicate with each other electronically, don't allow it. Lock it down whenever you can, and only explicitly open up channels when necessary, and then apply as many restrictions to those channels as possible. And the idea is if one part of your network gets infected, it minimizes the chances that the rest of your network gets infected. One good example, or one good anti-example, I guess, of this would be up until a few years ago, it was very common for larger organizations to provide vendor access via VPN, site-to-site VPNs, where the vendor's network was connected to the healthcare organization's network via persistent site-to-site VPN, and the communications between those networks were largely unrestricted. Not in all cases, some groups were better than others, but it was pretty common to have some network at a third-party vendor access to the internal network of a healthcare organization. Something like that is the opposite of what should happen. It should be as restricted as possible, as segmented as possible within reason. You don't want to make it too difficult for your employees to get their jobs done, but you also don't want to run the risk of having something bleed off into other areas of your network if you can prevent it. Email is its own can of worms, right? Virtually every healthcare organization and virtually everybody listening to this now, at one point or another, has seen or has done it themselves, sent PHI by email. Unless you have very specific systems in place to do that, i.e., your email is never leaving your internal email server, and your email server is encrypted and at rest and in motion and is compliant in every way, or you're using a third-party service, and there's a bunch of them that allow you to basically have what they refer to as secure email, where it generally requires you log into some portal to access the contents of the email, and many organizations out there have started rolling that out. Unless one of those two things can be checked off, just don't use email to transfer PHI. And if you do, make sure there's a lot of training, employee training around how to properly leverage email. Virtually nobody, unless you're in the IT sector, understands how email works under the covers, and so it seems like a safe thing to do. I'm addressing it to one individual, I'm attaching a file, how could somebody gain access to that unless they have access to the other person's email? But of course, IT people know the internal workings are not that way at all, and in many cases, those emails are flowing out over the public internet, and really, it's an immediate violation of the security rule. So try to avoid it whenever possible, or put systems in place to make sure that it's safe. And then finally, continuity. So this is just, there's a requirement, a HIPAA requirement, that you're able to provide continuity of care and ensure the availability of protected health information if you're providing care to patients directly, right? And so if you can't access your PHI, the quality of your care is inherently going to go down because you're not making informed decisions about that care. And so you have to have a plan in place for availability of your EMR systems and your ancillary systems that support patient care. You have to have plans in terms of backup and restoration of that data in the case of disaster recovery. There's many techniques to support this. There's highly available servers, things like clusters and web farms, and there's a wide variety of ways to approach this. You can do hot secondary data centers. That tends to be the most expensive possible option. You basically have to take whatever millions of dollars you spend in your data center and multiply that by 2 for something that's almost never used or is used much less than your primary. So you're bang for your buck's pretty low with that, but it's a reasonably reliable way, if done right, to make sure you have a highly available infrastructure. There are software-based continuity solutions. I have to mention this because Galen offers one, so I need to do a shameless plug for our Vital Center product. But software-based continuity solutions cover you in this scenario. As long as I'm able to see the patient's chart, document a visit, I can provide care. So it's a good way and less expensive way to provide continuity of care. Backups are a whole realm in and of themselves. Those backups, all of the same rules apply to those backups, by the way, that apply to all the other data in your environment. I mean, it should probably go without saying, but they need to be encrypted. They need to be encrypted at all stages of that process. So, you know, if you're doing a backup to a network share somewhere and then copying them to tape, the network share needs to be secured, obviously, and encrypted. The tape itself, the bits on that tape need to be encrypted. The tape itself needs to be secure, physically secure. Those backups aren't treated any differently from a security rule point of view, so they have to have all the same compliance requirements. You should have on and off-site backup whenever you possibly can. That used to be a fairly onerous and expensive task. These days it's actually pretty easy. There's a wide variety of vendors out there that have HIPAA-compliant backup offerings that you can sign a BAA with them and then have them hook into your backup system and have your backup stored off premises in the case of a serious disaster of your data center. Please, please, please test the restoration process. That should be part of your, you know, you should have a policy in place where at a certain frequency, monthly, weekly, whatever your internal IT staff and your organization deems fit, test the entire restoration process for each sort of level of backup you have. So testing, restoring of a web server, testing, restoring your data, restoration of your database servers, et cetera. A backup's no good if you can't figure out how to get the data out of it. So testing those backup restorations is absolutely critical. And document all of this. So documenting these help with the restoration process. It helps people know what to do should something bad happen. And it also helps, by the way, with your risk analysis and your, if you did have a breach or any kind of audit that occurred of your organization, it helps you answer these types of questions. Physical security, I'm not going to spend a ton of time on this, but this is obviously a place of great concern given the fact that physical theft is still a primary way that a lot of this PHI is breached. You know, making sure your servers are secure, your laptops and other places PHI live are secured. Having a reasonable policy for building entry into places that could furnish access to PHI. So having a front desk guard or what have you. I mean, Galen as an organization is about 100 people. Everybody knows everybody else. The likelihood that somebody could walk into our office and sit down and snag a laptop without us knowing who they are is zero, but we still have a policy in place. We still have security. We still have key codes and policies in place for that. We have fobs for building entry. That's a cost of doing business, and you got to have it if you're going to be compliant. And given this is a significant source of risk, it's worth that analysis and investment. And then finally, beware of social engineering. Make sure that you're aware and that your employees are aware of the risks that are just inherent in being part of the internet, right? These days, there are countless ways for you to be exposed to malicious activity in the form of email phishing attacks, social media-based attacks. I can trivially log on to LinkedIn and figure out all of the people that somebody knows and reference those people in a quick call to say, you know, hey, I forgot my door pin or what have you, and, you know, this is Jim from accounting or whatever the cliche might be. It's trivial these days to gather incredibly rich amounts of information about individuals and use that against them and really be quite convincing at it. Not to mention the fact that it's pretty easy for somebody to just, in many places, walk in, drop off, as I mentioned before, a USB key, and then have somebody plug it in and have it compromise a network, and that happens quite frequently. Or having somebody steal a laptop off a conference room desk without somebody noticing. And all of these elements need to be part of your training procedures to make sure that people are kind of aware of that. You know, if you see something, say something type approach. Risk assessments, you got to do these as part of your organizational policy. They're supposed to be done, this is the official quote from the security rules in terms of what a risk assessment is. But in terms of when they need to be done, it says as needed. I'd recommend doing them anytime anything might have changed. So you might do a review of them, or you should do a review of them at the very least on a yearly basis, and then a more thorough analysis anytime something might have changed. That includes things like signing on a new ISV, bringing on a new business associate in some way, any new systems you've put in place, anything like that. Those are all changes. A merger, a lot of organizations are going through mergers and acquisitions as the healthcare space consolidates. Those organizations should be very careful about having comprehensive risk assessments be part of that acquisition, because things change a lot when you bring on a whole other organization into your group from a security point of view and an exposure point of view. Keep full notes about these types of meetings. Again, this goes towards the documentation aspect I was talking about. These assessments need to be signed off by all of the important people in your organization. That's your security and privacy officers, and then your CIO, your CTO, all of the fancy C-level people should absolutely be signing off on these types of assessments. They're critical. It's a cost of doing business in the healthcare space, and they're absolutely critical for compliance. And this goes, by the way, for all of the policies that make up your information security policy documentation. You know, Galen has something like 20 different documents that make up our documentation. Every one of those need to be signed by this group of people and read by them, please. These assessments can be done internally or from an outside party. I'd personally recommend doing them internally, just because generally your internal resources are going to know your systems better than an outside party. The outside party, it might be faster. It probably won't be less expensive. And it almost certainly won't be as comprehensive, because there's always going to be that server underneath that one guy's desk that shouldn't be there to begin with, that would have been missed if you had done it with an outside party, probably. It's not guaranteed. Some outside parties are very good at this kind of stuff, but not always. So I won't go through all of the, into a lot of details of what should go into a risk assessment, but generally you're cataloging every place PHI lives, ePHI lives, what are the threats to that PHI, and what are the ways to mitigate risk to that PHI. The National Institutes of Standards and Technology actually have a very long and robust publication that talks about risk assessment methodology. I tried to read it. It's pretty brutal, but here's one of the diagrams from the documentation, and this is, I think, reasonably useful. It's a little small on the screen, so I apologize, but it's reasonably useful, and it allows you to kind of get an idea of the different steps involved and the different inputs and what should come out of the different steps in terms of assessing risk. You don't necessarily need to be quite this formal, but I do recommend building out a matrix of where PHI lives, what are the threats to that PHI, and what are the ways you're mitigating that threat. And then that matrix becomes your kind of jumping off point for reevaluating your risk later on, because if it's something missing from the matrix, whether that's a threat or whether that's a source of PHI, it very easily allows you to identify that and add it to the matrix, and also provides a really good kind of one-stop shopping for documentation. But in the end, the risk assessment drives change in all of the things you'd expect: screening policies, security measures, backup procedures, et cetera. All of the things that go into making your organization compliant and resilient to these types of risks. The risk assessment is a sort of driving force in defining those policies. Employee training is a big part of the risk mitigation process, and the letter of the law says bi-yearly, so every couple of years. It's pretty easy. It's generally an hour to an hour and a half of somebody watching a video. You can buy these videos from third-party vendors. I'd recommend doing them yourselves if you can, because you can have very specific information about your organization in the training. But that it's not particularly onerous to require that refresher on a yearly basis, so I'd recommend doing that, but the letter of the law says every couple of years. Make sure that it's confirmed in writing that the employees have taken that training and that they understand it, so that can be done via testing and things like that. Privacy should be included in that training, and ideally privacy training that's related to their specific job roles. Stress the implications of them violating the privacy rules in terms of them personally, not just on the organization basis. And then go over specifically what are the violation reporting policies in terms of who do you tell if you see a violation, do you think there might be a violation, and as I mentioned before, social engineering and general security. We're running out of time here, so I'm going to rush through some of these last few slides. Your BA and vendor selection, all of the same attention you pay to your own organization at least at a high level, you should pay that same attention to your vendors. You should demand all of their internal documentation and policy information about how they lock down their organizations. You should make sure that your BAAs are up to date. I mentioned this previously, in addition to any other contracting you have, like master service agreements. And make sure you pay special attention to any organizations that transmit or store PHI on your behalf. So if you're using a vendor that's like a cloud-based EMR vendor, for instance, that's a really good place to start. Make sure that that organization is fully compliant and can provide you with all of the documentation that they should have if they truly are compliant. Really, in the end, it's about demanding transparency, and it should be a significant element of your risk assessment policy. Penalty mitigation, if this is an easy one, I'll go through this one quick. It's documentation, documentation, documentation. A breach is going to happen, and the more documentation you have, as I said, the more likely you will survive that audit or that penalty phase without significant repercussions on your end. So the cloud, really the question on everybody's mind is it safe? So there's multiple vendors out there that have pretty significant offerings in terms of HIPAA compliant cloud services, the big ones being Azure from Microsoft and Amazon Web Services from Amazon. There's a bunch of other smaller boutique providers. These guys must offer business associate agreements. If they don't, they're not compliant. You can't use any third-party vendor that might store or transmit or have access to your PHI that won't sign a BAA. Amazon and Azure certainly do. If your cloud vendor doesn't, then you shouldn't be using them, and you need to get them to comply as soon as you can. Compliance in most of these cases depends highly on usage. So how you use their service and how the vendors and other third parties using their service really makes a difference. So there's many ways I can use Amazon or Azure that are not compliant. And it takes a lot of knowledge and experience to know exactly how to use those services without being out of compliance. And so the question really remains, are they safe? So in my opinion, given this is what I do every day, they are safe. It does depend, and there are reasons to be concerned, and you shouldn't just assume they're safe, but they are safe. And why are they more safe? So generally, they're more secure because this is all they do. You know, Azure is huge, for instance. I used Azure as an example. They were one of the first to offer a BAA and have compliance and a trust center that describes how to use their services in a compliant way. But they are compliant generally if you use them correctly, and they're safer because they're massive, and this is all they do on a daily basis. The implications for a breach for Azure are huge. It could be, you know, trust ending, and their entire business rests on trust. And they spend billions of dollars on infrastructure and technology and people every day with the sole purpose of making Azure more scalable, more available, and more secure. And there's no way that any individual organization can match their level of technology and their level of investment. It's just not possible, and that's one of the reasons why the cloud exists, right? These economies of scale exist, or these cloud service vendors exist because of these economies of scale, and this is one of the benefits of them. It's one of the reasons why the cloud is there to begin with. This just kind of gives you an idea of all the data centers around the world where Microsoft's cloud services exist. So they've got hundreds of data center, individual data centers with dozens of regions, that they call them. But you should still be cautious. They're a bigger target in the same way that using a Mac is generally safer than using a PC. That's mostly because a Mac, and this is probably a controversial statement, so maybe I shouldn't have used this example, but it's generally because Macs are less targeted because there's fewer people using them versus PCs. You know, if you've got 90% of people using PCs, that's where 90% of the opportunity is for hackers. And then also, again, it's very easy to use in a non-compliant way. You have to make sure that whatever vendor is using them, or if you're using them yourself, that you have a full understanding of the technology stack involved and how to make sure that you're always compliant. And again, demand transparency. I know we're out of time here. I just want to go through the software development lifecycle section. So when you're selecting a independent software vendor, or business associates whose primary goal is or primary offering is software, you should demand documentation about their software development lifecycle. What's the process they go through for developing that software? Do they do security analysis of the code that's produced by their developers? What does their testing process look like? Do they have automated testing and code coverage documentation that can provide you? What's the access control look like for their pipeline? So when the software is developed, until the time that the software is deployed in your environment, who has access to what and when. That's very important. If I am a rogue engineer and I have access to the bits that are delivered to a customer right before they're delivered to the customer, I can do some pretty nefarious stuff. And the only way to guarantee that that wouldn't happen is by having very clearly documented and enforced processes in place to control access to that. This is an older example from Galen's internal documentation, but this was one example of a software development lifecycle here at Galen where the developers' bits, so to speak, were checked in or their code was checked in, and we had a series of automated tests and verification process that went from environment to environment. All of these things are automated, so there's nobody physically installing software in a testing environment. It's all completely automated, and that's really required, both from a general development point of view and from a security point of view. Human approval is always involved at some point or another, but that human approval should be part of a robust locked-down pipeline, that has access control applied to that approval process. And any ISV that you're working with should be able to provide this kind of documentation to you. Some resources at the end here that you guys can peruse this at your leisure. These are all sort of the resources that I used during the building of the presentation, along with some really useful resources like the OCR portal for breach reporting and for existing breaches. It's helpful to go through that from a knowing where the risks are. The government documentation on HIPAA is actually quite good. Their websites are reasonably easy to understand, and so I link heavily to those in here. And then some general IT resources that talk about cloud infrastructure, software development, secure software development life cycles, and security checklists from an IT point of view. So I want to thank everybody for joining today. I'm sorry I ran a few minutes over. There's a lot of stuff to cover. And I do encourage you again to download the slides for this. There's a bunch of other resources in the notes for each of the slides that you can go off to and read about. And please do submit any questions you have in the Q&A panel in WebEx, and I'll do my best to get back to all of you in sort of a reasonable time frame. But thanks again for joining Galen today on our webcast, and I hope it was useful for everybody.